When I sit down with a patient for a genetic counseling session, a big part of what we do is go over the family history. And I think patients are surprised when we can easily spend 30 minutes just sketching out their family history. I have people prepare by talking to relatives and maybe even getting death certificates if they're able to confirm the types of cancers in their family. When we do a family history, we try to get at least a 3, if not a 4-generation pedigree. So we would include the patient, the siblings, the parents, sometimes nieces and nephews, aunts and uncles, cousins, grandparents, children, and sometimes grandchildren. So we basically go as far as we can with any known family history. When we're looking at the family history, obviously it's important to look at people who have had various types of cancers, but we also look at the context of the people, number of people and ages of people who have not had cancer. So for example, a woman who has a sister with breast cancer at age 51, but she also has 6 other sisters who are in their 60s and 70s with no cancer, probably has a less likely chance of having a genetic mutation than a woman who has that same sister and no other sisters and maybe only brothers. So the context can make a big difference as well. When we're looking at the people who have cancer, we look often at not only the type of cancer, but whether it was bilateral, where it was located. So for example, in colon cancer, we want to know if it's right-sided or left. Or if people are telling us it's a gynecologic cancer, we want to know, well, was it uterine? Was it ovarian? Was it cervical? So that we can identify which genes might be associated with that cancer. We want to know the age at diagnosis. So, it's important to know if somebody is age 75, but they had a breast cancer at age 40, we really care more about when the cancer was diagnosed than we care about their current age, because that would be a big red flag, knowing that they were early age of onset. Another red flag would be if a breast cancer were bilateral, if there were 2 primaries, maybe in the left breast and then 3 years later in the right breast, and not necessarily a metastasis. So those factors are all really important. I also look at the relationship of the different types of cancers in the family. So, if we're thinking about BRCA1 and 2, maybe we have a patient come in who has breast cancer. Maybe she has a nephew who had pancreatic cancer. Maybe her dad had prostate cancer, and then her grandma on her dad's side had some kind of gynecologic cancer that's suspicious for ovarian. So that would be a very classic, probably BRCA2 looking family. So those are some of the things that we ask about for family history. We also look for an autosomal dominant pattern in the family. So what I mean by that, autosomal dominant basically means you have 2 copies of a gene like this, and one of them has a mutation, and you have a 50-50 chance to pass that mutation on to the next generation. And so in an autosomal dominant family, you'll see a segregation of the mutation going on through a family, but sometimes it looks like it skips generations. And the reason for that is that the risk of associated cancer is not 100%. So each person in the family that has the mutation doesn't always develop cancer. So a lot of times there's misunderstandings about, well, it looks like it skipped my mom, but then it came to me. No, probably mom has the mutation, but she just didn't manifest with the cancer. Another common misnomer or misunderstanding about inheritance of breast cancer genes is that it only matters on the maternal side. But I think a lot of people are realizing today that the paternal side is just as important. And it's a lot easier for a family history of a female cancer to be masked when it's coming through the paternal side, because dad's usually not going to have one of those related cancers. So in a genetic counseling session, we really look at the big picture. We look for all of those different red flags. We also ask about ethnicity or ethnic background. So we ask about ethnic background because there are various ethnicities that have some increased rate of mutation. So the Ashkenazi Jewish population, or Jewish people of Eastern European descent, they're a classic group with about a 10-fold higher likelihood of finding a BRCA1 or BRCA2 mutation. So we look at that whole package and we do a risk assessment based on that family history to help the patient decide, based on the likelihood of finding a mutation, whether genetic testing might be helpful for them or not.
Hi, I'm Dr. Jay Harness, and I want to share with you important information that I believe that every newly diagnosed patient with breast cancer needs to know.
I'm a breast cancer survivor.
I am a breast cancer survivor.
I am a breast cancer survivor.
And I want every woman to know
About personalized breast cancer treatment
and the genomic test.
A test that helps guide a woman and her doctor
to the best treatment options for her.
Pass it on.